This professional education session, Mental Health in Older Adulthood, is part of our commitment at Right at Home to supporting you as you provide care with confidence. Leading the session is Matthew Fulen, PhD. His research, teaching, and advocacy focus on the mental health needs of older adults, with an emphasis on improving federal mental health policy and developing programs to enhance resilience and wellness and prevent suicide among older adults. Let's start talking about living.
We know that older adults, operationalized as people ages 65 and up, will increase from 58 million to 82 million in the next 25 years, which represents a 47% increase. And within this demographic shift, we anticipate more racial and ethnic diversity among older adults, higher education levels, older adults who are engaged in the workforce for longer periods. We also may anticipate somewhat of a plateau in life expectancy. After many years of life expectancy growing, we did see that level off a bit, in part due to the COVID-19 pandemic. So that is still something that needs to be looked at in more detail. And we also anticipate caregiving gaps with the growing number of older people and the higher proportion of our communities that is aging into older adulthood. We know that there will be certain gaps in terms of family caregiving as well as professional caregiving. Now, I want to make it very clear that on the whole, older adults experience high degrees of life satisfaction. There's a lot about aging that coincides with mental health, with very positive mental health experiences, and subjective well-being is particularly high when older people perceive that they have certain qualities and characteristics. So one of those is adequate social support, another, a sense of control and mastery. When older people have opportunities to derive meaning through paid or unpaid work, they experience higher degrees of life satisfaction. When they're able to participate in preferred spiritual or religious practices, and when they have a positive perception of their age, these are all ingredients that contribute to high degrees of mental health and well-being. And so, I'm very positive and age-friendly in the way that I think about older adulthood and mental health, and want to begin with the clear message that mental health is possible for older people. And yet we know that there are challenges, very real challenges that some people face. So let's talk a little bit about some of those challenges that interfere with the pursuit of mental health and well-being for older adults. On the whole, about 20 to 25% of older people meet the criteria for a mental health condition. And just to give a little bit of historical context, back in 2018, it was about 11% of older adults who reported depression or anxiety. This was from a survey related to Medicare. By August of 2020, so within about 6 months of the start of the pandemic, this number had increased rapidly to about 24% of all older adults, and nearly half of older adults who also reported their physical health as fair or poor. And so the effects of the pandemic are still sort of shaking out, but we do know that mental health not only became something that was more under duress during the pandemic, but it also put greater community awareness on the needs for mental health services for people of all ages, and older adults are not excluded from that. One of the factors, however, is that older adults tend to underutilize mental health services at a greater rate than other age groups. So while we know that older people have mental health needs that may be generally comparable to the rates of mental health needs for other age groups, they tend to have fewer access points to supportive mental health services. They may internalize more turmoil or doubt or stigma about using those mental health services. And therefore, there is this sort of coverage and service gap that is somewhat unique to older adults. So the first topic that we'll dive into is depression in older adulthood. And again, I want to start off with a clear message that depression is not a normal part of aging. even though it does impact a significant number of people. And I also want to highlight that depression is treatable among older adults. So when an individual is experiencing depression or depressive symptoms, there are treatments that can be effective in helping them to get better. When we look at lifetime prevalence among older adults, it's about 21% of older adults who at some point in their lives have experienced a depression. And again, these statistics primarily focus on those living in the United States. When we look at more community-based snapshots, so moments in time, up to 5% of older adults are currently experiencing what we call a major depressive disorder. And that would include a wide range of criteria that qualifies them for that particular diagnosis. It's more like 12% of older adults who would state that they're currently feeling depressed or are being treated for depression. And that difference between 5% and 12% has to do with the kind of severity level of the depressive symptoms, major depressive disorder having a more rigid criteria for what constitutes that particular diagnosis. When we look at rates of depression in particular contexts, the numbers fluctuate just a little bit, up to 13.5% for older adults requiring home health care, up to 11.5% in older hospitalized patients. And there's an additional 15% of older adults who we might say have subclinical depression symptoms. And by subclinical, we mean that they may not meet all of the diagnostic criteria for a depressive disorder, but they're still navigating some sort of clinically important depressive symptoms that may impact their mood, their day-to-day well-being, their relationships, etc. So we want to become sensitive to all of these different versions of how depression might show up in older adults' lives. And again, these are significant numbers. These are numbers of older adults that should, get us tuned in and really want to notice where anywhere from 10 to 20% of older people may be struggling in this way. And yet that does mean that 80 to 90% of older adults are not struggling with depression. And so once again, to kind of bring it home, depression, critically important to understand, but not a typical or normative part of the aging experience. Now, when we talk about different types of depressive disorders, there are several categories that I'll just briefly walk us through. So major depressive disorder, which I previously alluded to, this primarily focuses on 2+ weeks of symptoms that are interfering with the performance of daily tasks. In contrast, something like persistent depressive disorder, this is more of a low-grade depression that exists over a long period of time. In fact, over 2 years of having mild depression. And by mild, I don't mean that it's not still very impactful, but the task interference associated with persistent depressive disorder is a bit more limited compared to major depressive disorder. Depression can also occur in the context of substance or medication as a side effect or as some sort of kind of auxiliary symptom set that is being experienced alongside a substance use issue. Depressive disorder can also be secondary to a medical condition. This would be where the medical illness is fairly promptly followed by a period of depression. And a last category would be an adjustment disorder with depressive symptoms. This typically shows up when an individual is navigating some sort of significant life adjustment, and those depression or anxiety symptoms follow suit. Each of these categories is going to come with slightly different best practices as far as treatment, but all of these are important to pay attention to when we are serving older people. Now, a little bit more about depression in older adulthood. In about half of cases, depression first occurs in older adulthood, meaning that for those individuals, there wasn't a previous depression experience prior to reaching age 65. And for those individuals who have this first time onset of depression, there is some evidence that this may coincide with other cerebrovascular changes and the potential for elevated dementia risk. So we do want to keep that in mind, that individuals who are experiencing depression for the first time as they age, it may be helpful to go through some screening for other cerebrovascular changes. When we look at risk factors for depression in older adulthood, there's a wide range that the National Institute of Aging describes here. Everything from medical conditions to stress, sleep issues, social isolation and loneliness. There can be genetic factors that influence depression, lack of physical activity, functional limitations that are impacting their activities of daily living, as well as addiction or substance use disorders. So a lot of different factors that can contribute risk to older adult depression. And the National Institute on Aging puts out helpful infographics, helpful resources that remind people again that depression is common but not a normative part of aging, and it can impact the way that people feel, act, or think. And it encourages friends and family members to offer support and to try to mobilize resources to help a loved one who may be struggling. Now, when we look at depression in older adulthood, in contrast to some of the ways that younger populations might experience depression, older adults may be more likely to report anhedonia, which is the clinical term for a lack of interest or pleasure in daily activities. And they may be more likely to refer to that lack of interest or pleasure than kind of coming right out and saying, I feel depressed, or I feel sad, or I feel anxious. This focus on anhedonia coincides with some older adult communities having somewhat less mental health literacy and not being as accustomed to talking about mental health needs or psychological needs. And so when those sorts of psychological concerns, such as depression, are experienced, they may be experienced in a way that is more somatic or bodily, and they may be less likely to interpret the experience as depression. And so again, we want to tune into people that might be alluding to, I just don't feel like myself. I just don't feel like doing those hobbies or pleasurable activities anymore. That can be a hallmark sign of depression. Older adults, in comparison to younger populations, are also more likely to have sleep concerns, feeling slowed down, fatigue, experiencing hopelessness, or even having memory issues. And depression is more likely to occur with medical illness and commonly found with factors such as stroke, diabetes, Parkinson's disease, cardiovascular disease, and dementia. We could spend an entire session just talking about different approaches to depression treatment. But for the sake of time, kind of boil it down to a few different avenues, one of which is medication. So second generation antidepressants are typically in the SSRI, SNRI, or NDRI category. And there really have been good advances in depression, medication-based depression treatment. These side effects of these drugs tend to be fairly mild to moderate, which can make persisting and taking those SSRIs, et cetera, more effective. I do want to highlight that counseling or psychotherapy has been shown to be effective for treating older adults' depression. Specific types of therapy could include cognitive behavioral therapy, which is going to focus on the relationship between thoughts and behavior, interpersonal psychotherapy, which is focused on relationships and how people relate to the outside world, life review or reminiscence therapy, which has to do with looking at your life narrative and sort of reflecting on the life that you've lived, problem-solving therapy, which really zeroes in on specific task interference or challenges that the person may be navigating and coming up with solutions for how to work through those challenges. And I want to note that other approaches to counseling may also be helpful, but these are 4 approaches that have been studied and shown specifically to be effective in treating later life depression. A third category are health promotion programs that may be offered by an area agency on aging or a senior center. And there are 2 of these programs that specifically focus on treating mental health concerns, especially depression. One is called Pearls and the other Healthy Ideas. And both of these are delivered by trained lay providers who are able to work with the older adult to kind of navigate a structured curriculum that helps them work through depression. So again, depression, not a normal part of aging, but something that does occur commonly. And it's good for us to be aware of some of the ways that that shows up in later life and ready to help those individuals access certain forms of treatment. Unfortunately, we do see that older adults commonly have one of the highest rates of suicide per capita. You can see from the CDC's most recent data that individuals ages 85 and up were actually the group per capita with the highest rate of suicide. When we look at suicide risk in older adulthood, there are some interesting things to take note of. One is that older adult white men complete suicide at a rate more than double the national average. And that figure in the parentheses there is about 32 cases per 100,000 people. This rate increases to almost 51, or nearly 4 times the national average, for older white men over the age of 85. And globally, adults over the age of 70 have the highest rate of suicide. So this is a problem that we see in the United States, but it's not just a problem here. Clearly, there are certain challenges associated with growing older, and especially certain challenges with how we make space for people who are navigating later life, how we can make sure that they have the best possible experience, the most welcoming experience. Those are also suicide prevention strategies, is not only to identify and help individuals, but to try to make sure that we have community-based interventions that make space for people to grow old in the healthiest, most humane way possible. If you compare older adult suicide with suicide among younger groups, there are some notable takeaways. Older adults who died by suicide were less likely than younger people to admit to suicidal thoughts, which means that we have to be even more kind of tuned in to suicide risk with this population, knowing that they may not be quite as verbal about the suicidal thoughts that they may be experiencing. Older people tend to have a lower likelihood of having a history of psychiatric treatment. They're more likely to die during their first suicide attempt, which means that, again, we have to really have precise ways of identifying people who may be at risk, and we have to be willing to ask some difficult questions so that we can help those individuals at risk get access to care. Older adults were more likely than younger groups to use a firearm when attempting suicide, and they were more likely to seek help from a primary care provider rather than a mental health professional. All of these are factors, again, that make suicide risk in older adulthood especially concerning, and mean that we have an even more outsized responsibility as aging-related professionals, caregivers, et cetera, to talk openly about suicide risk and make sure that older people feel supported and feel like they can talk when they have a concern. I alluded earlier to elevated rates among older white men over the ages of 85. Just wanted to share briefly a visual aid that sort of depicts that. So if you see the top line in the graph that really spikes up toward older adulthood, in contrast to some of the other age, race, and gender demographics, you really see this sort of trend upward that takes place among white men, especially, who already have a higher rate of suicide, even in earlier phases of life. But that really does kind of take on a new exit velocity in comparison to some of the other age groups on that slide. Yates Conwell is a suicidologist who specializes in working with older adults. He describes the 5 Ds of late life suicide, which include disease, disability, disconnectedness, depression, and then having access to a deadly means of attempting suicide. And Conwell argues that when these 5Ds are represented, or to the extent that a person has one or more of these, their risk of suicide is going to be elevated. So we want to tune in to some of these specific ways that disease, disability, disconnection, depression can lead to a person struggling with thoughts of suicide. And then having access to a deadly means can really take us from a level of risk to a high or even higher level of concern. When we're looking for warning signs related to older adult suicide, direct or indirect statements that indicate a frustration with life and a desire to die, a sudden decision to give away prized possessions, a general loss of interest in one's environment, or feeling isolated or cut off from others. These can be warning signs. They're not the only warning signs, but they are four that are important to pay attention to. And just some brief resources. We have a national lifeline, 988. Your local area agency on aging may have additional resources, including mental health resources in your community. Your community likely has a community mental health center or a community services board that offers mental health care. And your agency may have specific crisis protocols related to something like suicide. If the agency's crisis protocols don't include suicide risk, this can be a really good conversation to have about trying to add something to the crisis protocol, knowing that older adults do have this elevated risk of suicide. Among older adults, we see rates of up to 15% in community samples and up to about 28% in medical settings. And notably, when we're looking not so much at specific diagnostic criteria, but clinically relevant symptoms or sort of those subclinical anxiety symptoms, the numbers really expand markedly. Anywhere from 15 to 52% of older adults in community settings have some sort of clinically relevant anxiety, and 15 to 56% in medical settings. So a wide range, depending on the study that you're looking at. And a lot of this has to do with the severity level of anxiety. But a lot of older people navigating anxiety. And for most anxiety disorders, the prevalence decreases as we age relative to younger adulthood. But with generalized anxiety disorder, that's actually goes in the opposite direction, where there's a similar prevalence for younger and older people. When we look at causes of anxiety in older adulthood, there are some neurobiological changes that older adults experience that make them more vulnerable to having trouble offsetting worry that pops up. So if you think of your brain as having like a gas pedal, where anxiety might notice something that is awry and make you more and more aware of that, and then a brake pedal that helps you to be able to calm yourself down, re-regulate, and maybe even kind of talk yourself through that anxiety. As we age, we experience neurobiological changes that mean that brake pedal becomes a little bit less effective. We have to step on the brake harder in order to make it work. And so that can result in the anxiety gas pedal getting a little bit more out of control, speeding up without us being able to tamper it down. Older people may experience health questions, uncertainty about what to expect health-wise, or maybe worry about cognitive impairment. There may be social stressors related to partners, friends, loss. There can be challenges with adult children. There might be a lack of reciprocal relationships where the person feels like I'm not only giving, but also receiving. There might be environmental challenges, the prospect of having to relocate, financial stress that emerges. And there can be other vulnerabilities as well, such as a history of anxiety, medical illness, stressful life events, personality traits that are more geared toward anxiety, and a lack of social support. How do we know when normal stress becomes subclinical anxiety and when subclinical anxiety becomes an anxiety disorder? One way that we can try to measure this is when worry becomes chronic and pervasive. when it increases beyond what most people would experience under the same circumstances, when a person finds themselves focusing on worst case scenarios, avoiding certain situations, constantly seeking reassurance, feeling on edge or having difficulty sleeping, or when the anxiety is getting to a place where it's impairing other tasks or other engagement. These can all be examples of how normal stress evolves into something like an anxiety disorder. At the same time, when we look at older adulthood, stress is normal. Older adults outperform younger people when it comes to remaining calm during times of stress. So this is not to say that all of aging is about becoming more and more anxious. It simply means that we want to keep an eye out for older people who may be going from that sort of normal stress to something that is much more challenging to deal with. And similar to what I shared with depression, anxiety disorders are not a normative part of aging, even though they do impact a significant number of people. When we look at anxiety experiences compared to younger populations, there's a lot that's in common. Older adults may emphasize the physical manifestation of anxiety and may not be as quick to identify the cognitive experience of worry. Some of this, similar to depression, may be due to lower rates of mental health literacy and not being as accustomed to thinking psychologically about a particular experience. But this is going to vary a lot depending on your context. Some older adult communities may be very tuned in to mental health needs, others not as much. And we see the same thing in younger populations as well, where some younger communities are very attuned to mental health and others not so much. When we look at onset of anxiety with generalized anxiety disorder, almost half of older patients had an onset after the age of 50. And this is sort of in reverse of what I shared about depression. Those with initial onset younger than 50 have more severe cases and more pervasive worry, whereas those with an initial onset after the age of 50, it tends to be a little bit more mild and manageable. Risk factors for a later onset GAD can include chronic illness, disability, caregiver status, social isolation, institutionalization, and bereavement. Now, it's good to note that anxiety is frequently comorbid with other diagnoses, meaning that it's diagnosed alongside something else or it's existing alongside another condition. 13 to 23% of older adults with anxiety disorders also had a depressive disorder. Anxiety and depression can look somewhat similar. Both can lead to irritability, restlessness, concentration issues, sleep issues, and fatigue. When you have a case of GAD and a depressive disorder, it can lead to elevated suicide risk, as well as increased somatic symptoms. And this combination can also lead to an increased risk of cognitive impairment. Older adults with both depression and anxiety symptoms typically needed about 50% more time for an antidepressant medication to work. And this group of people with both anxiety and depression were more likely to discontinue treatment, in part because it took longer for those antidepressant medications to kick in. So for those who are navigating both of these challenges at once, it can become even more complicated and more challenging. Anxiety symptoms in older adulthood may increase the risk of cognitive decline. And there's a lot of research going on about this sort of bidirectional relationship. So on one hand, anxiety increases our allostatic load, which means that our brains are having to do more work because of the stress that we're experiencing. And at the same time, having cognitive impairment that is starting to show up can trigger anxiety and worry in the older adult. So that's the bidirectional relationship that researchers are looking at. There's a link between chronic anxiety, severe worry, and cognitive decline, but the pathways are not yet clear. But some of the candidates for what could be contributing to this are things like chronic stress, increased cerebrovascular burden, chronic inflammation, glutamate excitotoxicity in the hippocampus and prefrontal cortex. And so again, the jury's still out on exactly how these different mechanisms are working together, but there's clearly some sort of relationship between anxiety and cognitive experiences, cognitive decline. When it comes to treatments for anxiety, once again, medication can serve a purpose. First line of defense is SSRIs, as well as some other treatment options. In a more acute situation, you may have a patient who's diagnosed with anxiety receiving an anxiolytic. These can help resolve anxiety in a more immediate way. However, these drugs also have an increased risk of memory impairment, falls, and withdrawal symptoms, and they tend to be overprescribed among older adults. So we have to navigate that anxiety medical treatment pretty carefully due to the over-reliance on these anxiolytics and benzodiazepines. For counseling interventions, cognitive behavioral therapy can be useful. Applied relaxation, where you're helping people respond in moments of acute anxiety by teaching themselves rapid relaxation, and an approach called acceptance and commitment therapy that teaches people how to stay grounded in the present moment and follow their values and to not let worry and anxiety interfere with some of the goal-directed choices that they make. These can all be helpful interventions as well. With alcohol specifically, 20% of adults in their early 60s report binge drinking. The number's more like 11% for everyone over the age of 65. But what's interesting is that the definition of appropriate alcohol consumption does change somewhat in older adulthood due to physiological changes that older adults experience. So the dietary guidelines from the federal government are a maximum of 2 drinks a day for men, 1 drink a day for women when it's alcohol that's being consumed. And these guidelines also state that older adults should have no more than 7 drinks in 1 week and no more than 3 drinks at a particular time. Alcohol can become more problematic in older adulthood due to the ways that aging decreases the body's tolerance for alcohol. And this can lead to experiencing the effects of alcohol more quickly than a person experienced in younger years. And that elevates the risk for things like falls, automobile accidents, and unintentional injuries. And so if you think about someone who has enjoyed alcohol over the course of many decades, they may have to make some pretty significant adjustments to their own expectations of how much alcohol they can consume. What they consumed 5, 10, 15 years prior is going to have a much larger impact on their body and brain functioning in older adulthood. And so there's an adaptation that must happen so that they are no longer expecting that it's okay to drink a certain amount just because that's what they've always done. When we look at problematic alcohol use, about 2/3 of individuals who meet those criteria are early onset, meaning that they've been drinking for many years and have aged into older adulthood with some sort of problem drinking already at hand. In about 1/3 of cases would be late onset, where the problem drinking shows up for the first time in older adulthood. These individuals with late onset may have had a more recent stressful life event. It could be the loss of a partner that triggers the problem drinking, retirement, having a difficult adjustment to a physical impairment or to a medical illness. These can all be factors that may prompt a person to begin using alcohol as a way of coping with these stressors. According to Lehman and Fingerhood, there's several different signs and symptoms related to problematic substance use. You can see here sleep disturbances, mood swings, irritability, anxiety, and depression symptoms. These can all be signs that problematic substance use is taking place. There can be physical symptoms like nausea, vomiting, coordination issues, or tremors. With older adults who have unexplained injuries, falls, bruises, evidence of malnutrition or self-neglect, poor hygiene. These can be additional factors that may suggest problem alcohol use. Older adults who are feeling confused, disoriented, having memory impairment, impaired reaction time, and then social and behavioral changes as well. Things like withdrawing from usual social activities, family conflict that seems to have emerged, premature requests for refills of prescription medications. All of these can be evidence of problematic substance use. When we look specifically at prescription medication, older adults have some elevated risk, in part because they are prescribed so many different medications. And so just having access to more medications and that being something that they are more accustomed to engaging with can lead to misuse. And misuse can show up in a variety of different ways. It can be having higher or lower dose than prescribed. It could look like using a medication for a longer duration than is prescribed. It could be using prescription medication for recreational or non-medical purposes, or using someone else's medication outside of what the prescription is intended for. When we look at misuse of opioid prescriptions in particular, and this would be defined as use of an opioid without a prescription or in ways not intended by the prescriber, there's kind of a wide range depending on age groups. So if you start in the lower right-hand corner, over 19% of individuals between 55 and 59 reported problematic opioid use. That number dropped to 14% in the early 60s, dropped to 9% for those in their late 60s, and then continues to drop some all the way up into the person into their 70s and 80s. I do want to point out that this study was done to look at this in sort of a moment in time snapshot. And so we do see that there is this range between 4% and 19% of midlife and older adults who reported some sort of prescription drug misuse. But we also want to keep in mind that as opioids continue to be a prominent way of dealing with pain management, that we might see these numbers continue to fluctuate in future years as well. Interestingly enough, in the same study, when they asked individuals the reason why they misused opioids, the vast majority, 85%, said it was to relieve pain. 16 to 17% said it had to do with sleep or relaxation, 6% to help with emotions or to get high, and a real small percentage that wanted to experiment, felt like they were hooked, things of that nature. Now, when we look at some of these problems with prescription and over-the-counter medications, again, these prescriptions may be used, they may be given out in order to treat things like anxiety, depression, insomnia, other mood disorders. And we know that older adults routinely use other over-the-counter medications as well. This information comes from SAMHSA and highlights many of the factors that can increase in older adults risk of medication misuse. Things like having multiple physicians prescribing multiple drugs just means that with polypharmacy, there's more possibility of misuse. Inappropriate prescribing, when instructions and package inserts are written in a way that makes it hard to read, either it's confusing language or the print is too small. There can be times where a medical provider may not have a thorough conversation about the use of over-the-counter medications, vitamins, and herbal supplements. When there's memory impairment, that can lead to prescription misuse. And there can also be prescription misuse that travels alongside alcohol use, depression, or self-neglect. And when those things combine, that can be especially challenging. So many risk factors for what can contribute to substance use in older adulthood. And again, this is something that as care providers, family members, community members, we want to really be mindful of. I want to walk us through a brief framework for how to address mental health concerns in older adulthood. And this framework is really meant to be pliable regardless of what your specific role is. This can be something that's useful for professional caregivers, as well as mental health and healthcare professionals, but it can also be a helpful framework for friends, family, and community members. And this Deliver framework is something that I've worked with and shared with other community providers in hopes that it can help get you started when you run into an older adult who may be struggling with depression, anxiety, suicidality, substance misuse, that these can be starting points so that even if you are not technically trained as a mental health provider or a healthcare provider, you still have some good go-to resources to help you respond in the moment when it's needed. So the first part of the framework is to draw upon the older person's strengths. And these strengths might include things like wisdom, this not being the first time that they've faced adversity. Older people oftentimes have a bank of experiences to draw from, and they may actually be more focused on the present moment due to some of the brain changes that occur in later life, which can allow them to shift orientation and be more mindful of the here and now. And that can be a very adaptive perspective shift when people are navigating later life. I ran a study and one of the participants said, older adulthood is not what's left over. It is its own vital component of life, not just what's left over after you were young. And I really think that is at the crux of this, is that in spite of many mental health needs, including those that are unmet, we do know that older people bring with them a wide range of strengths. And if we can help tap into some of those strengths and remind people and remind ourselves of what older adulthood is really about, that can be a really good starting point. Now, the next part of the framework is to demonstrate empathy, to empathize with the person's concerns. You can use active listening and curiosity to elicit more of the story. You can try a statement like, you're feeling down right now. Is that right? Or you're feeling really worried right now. Am I understanding correctly? You can share with the person, I'm glad you reached out to me about this. You're really going through a lot. Or you might say something like, it sounds like having to relocate away from your family has been very painful. Thank you for sharing that with me. And you can close with something like, what you're sharing really has my attention, and offer then to look into ways that you can connect them with additional resources. Getting comfortable with these sorts of kind of active ways of engaging with the other person, not trying to sugarcoat what they're going through, not trying to ignore the hardships that a person might be talking about. These can make all the difference in helping them feel understood and feel connected. We want to lean into the present moment, communicate your presence and your kind of willingness to be there with them using both verbal and nonverbal cues. That can mean slowing down if we're in a rush. That can mean putting our phone away so that doesn't become a distraction. Letting the person know that we really are tuned in. Even if we just have a few minutes to do so, those few minutes of really tuning in can make a big difference. We can convey respect for the person's decision to seek help or to open up about their challenges. And we can emphasize the reciprocity that is in the relationship that we have with them. And again, whether we're a family member, community member, neighbor, or a caregiver or healthcare provider, we can say something like, hearing you talk about your story reminds me why I'm in this role, or reminds me of how much I care about you. I care about you and I'm here to help. So you can tailor these statements to the role that you have, but being able to really embrace what the other person is sharing and to be able to convey that sort of therapeutic presence through your attention and through some tender words can be something that kind of serves as the starting point for helping older adults with mental health concerns. You might also spend a couple of minutes talking about their support system. So identifying that support system, who matters to you, to whom do you matter? Where do these people live? When did you last speak with them? Do they know that you're struggling right now? Older adults, by and large, benefit from relationships that they perceive as supportive, that provide a sense of mattering to others. So knowing that the older adult matters to someone else makes a big difference. Relationships that give the older adult an opportunity to extend support to others, not just be a recipient of support, but to convey to older people that they are helping you as well, they're benefiting you as well, can be a nice way to feature the reciprocity in your relationship. And older adults benefit from relationships that contribute to this notion that they have what they need to navigate later life. Now, we want to make sure that we verify safety, especially given concerns about suicide risk. Use whatever sort of risk assessment protocols you have within your agency or within your workplace. And if you don't have protocols, I strongly encourage you to bring that up and to try to develop some with your organization. But specific questions that you might consider alongside these protocols: are you considering suicide? Are you safe? What keeps you going? How have you survived? We don't want to leave it up to a guess whether or not the person is considering suicide, especially if we've already identified some of those warning signs that we talked about previously. A couple of other things to close out the framework. We want to expand the treatment lens. We want to be able to think about all of the biological, psychological, and social needs of this individual and how we might prioritize this holistic way of thinking about their needs in whatever context we're working in. And I know that time is limited. People have a lot of different older adults that they might be serving. And so it can be overwhelming to think about all of the different contextual needs that the person might have. And yet when we can try to expand the lens, we tend to get more of the person, more of their kind of holistic ways of making sense of their lives. And we avoid the sort of medical reductionism that can occur as older adults are seeking out treatment. The final part of the framework is that we want to gain comfort referring people to community resources. So developing a community resource Rolodex, whether that's your local senior center, area agencies on aging, making good connections with primary care providers, churches, and other houses of worship, and trying to develop more warm relationships with mental health professionals so that you could theoretically do a warm handoff. That could be a really helpful piece of developing your community resource Rolodex. Having other go-to referrals that have worked for you, worked for your context can go a long way. And ultimately, not only telling the older person about these resources, but assessing their level of interest, their level of motivation to follow through. And if they seem a little bit reluctant, it's okay to ask a couple of questions about, what's getting in the way for them? What do they feel nervous or unsure about? And maybe it's something that you could help them navigate, or maybe it's something that you could help them overcome a little bit of that uncertainty, so that they can follow through and get whatever sort of community resource will really be most helpful for them. And ultimately, the warmer the handoff to any of these resources, the better. You are finding yourself as a trusted professional or a trusted caregiver or friend. And so when you're able to help somebody know that there is hope for them, there are resources in the community, and here's specific resources that I would encourage you to check out, that can really go a long way in helping motivate the person to do just that. That's a custom framework that you won't find online because we haven't posted it anywhere yet, but it's just for webinars such as this one to be able to help people think about the different roles and tasks that they might be able to offer. Physical activity, exercise, continuing to maintain your body in whatever way works for you. Those can be really important preventative measures. Physical exercise gets our blood flowing, keeps our brains sharp and active. Those also tend to be things that we do in community. And so there's, a lot of relationship benefits that can come from that as well. And so those become really nice ways to buffer against depression, anxiety, etc. We know that there have been, if you kind of chart based on birth cohort, there are some different attitudes depending on when you came of age and what was the predominant messaging around mental health when you came of age. So for some older people, especially those who are, who were born maybe in the 1930s, 1940s, there may be more stigma because mental health care wasn't talked about as openly. And those individuals who did have mental health concerns, they may have experienced something like a psychiatric hospitalization or psychoactive drugs that were not as effective at that time. And so there can be some of these connotations with mental health that some older people continue to have to this day. At the same time, that is changing. So for example, the boomer population or the boomer generation, much more likely to have come of age where mental health and therapy was becoming more commonplace, more ubiquitous. And so those individuals may be more open, may have a mental health history that they point to, may have already worked with a counselor at some point in their lives. The other interesting thing is that, these differences based on birth cohort will just continue to sort of evolve. So when you think about something like, today's 65-year-old compared to someone turning 65 in the next 5 to 10 years, we would anticipate even more openness to mental health, which can mean even more willingness to get mental health treatment, and even more demand for mental health services. So it's not a static phenomenon. It's something that is moving, but I appreciate the question. There's definitely reason to think that certain cohorts have had more of that kind of built-in trepidation or hesitation about mental health care. The last thing I want to say about this, though, Victoria, is that even with older adults who have some of that generational stigma, when given information about what mental health care looks like today, when given access to mental health treatment, especially forms of treatment that are more comfortable and are sort of geared toward the older person's preferences. I can speak from a lot of anecdotal experience and clinical experience that older people are willing to engage when given full explanation of what this is, how it will help them, how it's something that can really help them meet their goals. And you see some of that stigma dissipate. I think sometimes we anticipate a high degree of stigma, and then we don't even offer the services because we sort of preemptively pull them back. I would encourage people to think about age-friendly ways to expose older adults in their community to mental health services, normalize it, and kind of see what happens at that point. Some older people, we're going to encounter them, and they really have a litany of challenges. They're really struggling to feel like they have a reason to look forward to tomorrow, and they may struggle with a lot of hopelessness. I'm a firm advocate of engaging those individuals in whatever sort of mental health treatment and support that we can. And, it's possible for individuals to feel very dismissed or feel very much like they don't have anything left to look ahead to. And for that to dissipate as we really pay attention to those needs and as we help people identify maybe some different ways of looking at their lives and at the ways that they want to engage with their communities. So, there's no person that we want to give up on, even if that person has given up on themselves. And we want to provide every possible measure of support that we can so that we can help those individuals turn the corner.
If you found this video helpful, explore more professional education here on our Right at Home YouTube channel. Subscribe to stay up to date on the latest insights, practical tools, and real-life guidance to support those in your care.